I would like to invite our chairs for the next session, Dr. Ali Asghar, Professor Zaman Sheikh, and Dr. Bashir Hanif. And our next speaker is Dr. Zahid Nabi. He's a consultant nephrologist, and he would be talking on the role of Finerenone in cardiorenal and metabolic disorders.
Assalamu alaikum. Good morning, or maybe now afternoon. Just give me 1 second only. First of all, I'm really thankful to the organizing committee who gave me this opportunity to be here in front of you all, and also Hilton Pharma, who is probably sponsoring this activity. For the next maybe 25-30 minutes, I'm going to talk about a drug which you all are very well versed with and familiar, and probably it is a part of your day-to-day practice as well. So I'll take you back, before talking about Finerenone, I'll take you back to 1999. And our cardiologists, they know very well that this was a very famous trial, Rails trial, which was published in New England Journal of Medicine. And this was the first trial which showed that spironolactone, it has shown promise in reducing mortality in those patients who had heart failure, and their ejection fraction was less than 35. There were two groups. Each group had around 800 plus patients, and they were followed up for 3 years. And the most striking thing was that it showed this benefit. And you can see the two curves, the two worms, they're far apart, showing that the drug showed a promise that it has a survival benefit. It was a great breakthrough, and from there on, this concept of using spironolactone in heart failure just came, and then it became just a part and parcel of all the cardiologists managing heart failure. The problem was, I won't say problem, but there was a small catch in it, because we know that most of the time our patients who have heart failure, their ejection fraction is less than 35% or so. They are suffering from diabetes, and then they have chronic kidney disease as well. So the exclusion criteria was that patients who had a potassium of around 5 or so, they were not included. Obviously, they were excluded because of the fear of hyperkalemia. And if the creatinine was more than 2.5 milligram, they were also excluded. So a major portion of our day-to-day practice patients, they were excluded from the trial, and that was, we can well appreciate, because what was the reason and the fear behind that, because the drug might cause hyperkalemia, and then it can have serious consequences. So why spironolactone was chosen at that time to be used in heart failure patients? Because we know it was an aldosterone antagonist which has a weak diuretic effect, but was it just a diuretic effect for that it was used, or it was something else? Obviously, there was a lot more than a diuretic effect, and that was, you could see that primarily the main theme behind was that it has an anti-inflammatory properties, and that was through multiple mechanisms. And in the heart, the fibrosis, which usually is mediated through TGF beta, and there are other fibronectin and collagen deposition and so many other things which in the vasculature leads to fibrosis and endothelial damage, oxidative stress, and so on and so forth. So it was proposed that spironolactone is the drug which reduces inflammation, which reduces oxidative stress, and that is the reason why you have seen a mortality benefit in this trial. Then over the years, there's another drug which has developed. Obviously, it took a lot of years to develop a structure which is a bit different from spironolactone. And why that was needed? It was needed because the problem with spironolactone was that there were so many off-target effects leading to side effects like gynecomastia and hyperkalemia. So we were looking for a drug which does not cause that much hyperkalemia, but at the same time, it should help us in reducing inflammation and protecting our vessels. So Finerenone was the drug which was blocking the mineralocorticoid receptors, and by that way, you could see that the endothelial dysfunction, which was because of the overexpression of the mineralocorticoid receptor, that was being taken care of in the kidneys, the deposition, mesangial expansion, the in the heart, the fibrosis, all those things, they were taken care of. But how finerenone is different from spironolactone? Two main things. One is that it is very potent and selective. As I said, spironolactone and eplerenone, they were a bit non-selective, so that's why there were side effect profile. And then it has very strong anti-inflammatory effect, which was far more than spironolactone. And the most important thing is that the risk of hyperkalemia was lower with finerenone. So we were moving forward to a drug which probably at the same effectiveness as spironolactone, probably more than that in reducing inflammation, but the side effect profile was less than that. And again, it is the same continuation of the same thing, that it exhibits anti-fibrotic and anti-inflammatory effects that were far more than spironolactone. And again, this is the same concept. So what we were doing with finerenone was that we are getting MR, which is mineralocorticoid receptor antagonism. So by doing that, we are protecting our heart, kidneys, and at the same time blood vessels, so to some extent retina and skin and adipose tissue. The most important thing about the difference between finerenone and spironolactone, if you can concentrate, I don't know, I have maybe this one, yeah. So you could see the half-life of the drug. So the half-life of spironolactone, it was far more, it was around maybe 20 hours or so, and that was the reason that it was causing a lot more hyperkalemia, and at the same time the distribution of the drug was not similar as compared to finerenone. So this was one of the major difference between the two drugs, other we have already discussed. So now the idea was way back in 1999. The drug had shown promise, but it could not be generalized and used to a major population which are suffering from heart failure and which have kidney disease. So that was the background. The dilemma and the problem is that 40% of our patients who have type 2 diabetes, they end up in diabetic kidney disease. And then 50% of, or 50% or more, ultimately, they will have fatal cardiovascular event. So it's a combination, it's a combo. You know, you have diabetes, chronic kidney disease, and then cardiovascular events and mortality. So that from there came this concept of cardiovascular kidney metabolic syndrome. And you all are well aware that there was a presidential advisory published in circulation by the American Heart Association. It's not a syndrome per se, like we all know, but it's basically, I would say, it's basically a conceptual framework where we need a holistic approach to tackle all these three things together with the help of a nephrologist, cardiologist, and all of you, the endocrinologists, which are probably the main people to look after these patients. So they define different stages from low risk, where there is no risk, and then up to where there is a fatal cardiac event. You don't need to remember things. It's not a syndrome as such in the literature. It's, as I said, it's a conceptual guideline, so that we should have a holistic approach, and that is again what just was taught a short while before, that we have to avoid this, and this is the first step where there is obesity, and then we move on into that direction. So 1999 spironolactone, and then it's 2015. We all probably are not as a clinician not familiar with this trial. We are more familiar with the two famous trials which came later on. But this was the first trial published in 2015, and that was in JAMA, which showed for the very first time that finerenone, it reduces albuminuria in patients with diabetic nephropathy. And this was a randomized clinical trial. It was not a small trial. It was carried out in 23 countries. And the dose of finerenone was ranging from very small dose of 1.25 up till 25 milligram. And it was completed in August 2014 and then published. So ultimately it showed that they checked at baseline urine albumin creatinine ratio and then day 90. So the drug showed promise in 3 months' time. So they concluded by saying that by adding this drug to those patients who are already on ACE and ARB. So you remember 2014-15, it's all ACE and ARB for diabetic nephropathy, nothing more than that. So addition of Finerenone would lead to reduction of albuminuria, which you all are well aware that that is one of the surrogate marker which we all look for, that it slows down the progression of chronic kidney disease. And then it took another maybe 6 years or so, and then came the landmark trial. So this trial was published in New England Journal of Medicine. You all are very well familiar with the trial. This was the Fidelio DKD investigator group trial, which was looking at the effect of Finerenone on chronic kidney disease outcome in type 2 diabetes. And this was followed by another landmark trial. So these two trials, they changed the whole management plan of diabetic nephropathy, the Fidelio, and then the next trial was Figaro DKD trial. It was the same group which was working on this drug in 2015. So what they looked in Figaro was the cardiovascular component. In Fidelio, they looked at the kidney component and the outcomes, kidney outcomes, but here they looked into the cardiovascular component. And if you look into it, it showed a great promise. That's why it has now become just part and parcel of every diabetic nephropathy treatment, and our worthy cardiologists could comment that they are using it in heart failure patients as well. So Finerenone, it significantly showed, slowed the progression of chronic kidney disease. That was around 18% versus placebo. And in Figaro, they showed that it reduced cardiovascular morbidity and mortality. So any drug which is reducing mortality and morbidity, obviously you cannot ignore. So that's why it became probably a standard of care for these patients as well. So now we have Figaro, Fidelio, but then we move forward. This basically is showing again the same trial. If you could see that the patient population was chronic kidney disease stage 3 and 4 once they were looking for kidney disease outcome, and it was 1 and 2 once they were looking for cardiovascular. And if you concentrate, the primary outcome here was secondary outcome here. And then this is crisscross. You could see that both trials, they were complementing each other, but primary outcome and secondary outcome were different, but in fact they were just complementing each other. So to pool this data, Figaro, Fidelio, and this was the trial, another very famous trial, one after another. And this was basically a pool data of both Figaro and Fidelio, which showed the same concept and probably a proof of concept that Finerenone is a drug which we all should be looking at. And what it showed basically, as I mentioned, Fidelio was published in 2020, then in 21, and then this pool data came in 2022. And there were almost 13,000 patients in this, because it was a pool data of these two trials. And they were looking at composite kidney, that was renal death or sustained GFR decline, and then composite cardiovascular, that was again cardiovascular mortality or morbidity in terms of fatal, non-fatal MI or stroke and these kind of things. And if you could see this forest plot, which showed that everything is favoring Finerenone. And these are the composite cardiovascular outcome. If you see the confidence interval and the strength of the study, this favors Finerenone. And then you look at the GFR reduction, it was again in favor of Finerenone. So now, starting from spironolactone, now we have a drug in 2022, which shows benefit in terms of cardiovascular mortality and chronic kidney disease progression, which is something quite huge. And the fear is always of hyperkalemia, which was, you could say, a little more, but that was not very significant. But yes, the drug still has a capacity to increase your potassium level, but that was not very significant, and that was the safety outcome in the Fidelity pool data. One can argue that you are talking about a drug which has been used in a very controlled environment. and that is a randomized controlled trial where the characteristics of the patients are similar and there are pre-specified inclusion criteria, exclusion criteria. But can this drug be used in real world? Like you are doing your clinics, I am in my clinic. So random patients are coming, someone may be 50 years, someone 80 years, someone has multiple comorbid, other might not have. So again, to look into that this drug is really safe in day-to-day practice outside of a randomized controlled trial. So this was published, Finerenone trial in Journal of Nephrology. And this is basically an ongoing trial which is going to finish in 2028. The interim analysis was done in June 13, 2023, and that was around 556 patients. And again, it showed that because it is initiated at various clinical settings and different population of patients, the treatment discontinuation and occurrence of hyperkalemia was low, the fear of hyperkalemia. But again, this is an interim analysis. You might see the actual data way back in 2028, what it shows. But interim analysis again favors that this is a drug which you can very easily use outside that randomized controlled trial in your day-to-day practice. And from there came an idea, like anyone can think that a drug which is anti-proteinuric activity, which is anti-inflammatory activity, which has anti-fibrotic activity. And as a nephrologist, we know most of our diseases, which are not diabetic, they have the same pathophysiological process going on, whatever the etiology is. So they are just moving forward other than diabetes, you know. This is a trial, FIND CKD trial, where they are now looking about the role of Finerenone that is beyond diabetic kidney disease. So that is something very fascinating for nephrologists, maybe not for all of you, because most of the time we might not have that drugs in our armamentarium which we can treat different multiple glomerular diseases like FSGS, IgA nephropathy, MPG, and so many things. So this is a drug which is probably going to show promise again in non-diabetic chronic kidney disease. This is a FIND CKD trial. Still, we are on it. The results are not yet on. So the first patient was enrolled in 2021. In May 23, it was completed. But it was again a multi-center trial which is done in almost 24 countries. And if you could see, that around 1,584 patients have been randomized, and all over the world, Asia, America, Latin America, Europe, and the mean GFR is 46, the mean albumin creatinine ratio is 818, and you can see the diversification, you know, the glomerular diseases. So it is the first phase 3 trial of Finerenone in patients with chronic kidney disease of non-diabetic etiology. And it is probably looking at expanding the role of Finerenone beyond diabetic proteinuric kidney disease. This is a question for all of you, because you know better than anyone how to tackle this type 1 diabetes. And again, my question would remain the same. So if you are using a drug which has shown promise in type 2 diabetes, what about type 1? So I know all of us, you will say that the pathophysiology is totally different, because type 1 is primarily an autoimmune phenomena where there is CD4, CD8 cells destroying your pancreas. Type 2 is a different pathophysiology. But at the end, downstream, you would say again there is an inflammation or so. So can this drug be used in type 1 diabetes? This will be the answer. You know, so people are working on it to look into it. That FIND-1 is the trial which is looking into it. So if the drug can be used in type 1 diabetic patients, and if proven, up till now we don't have the final data, but if proven, this probably could be the first drug in 30 years which could show some promise. And the way things are, maybe this is one of the drugs which might we all be using in type 1 diabetics, but I'll just leave it to you, because you are the master of this disease and you can know better than me what to do. But what I'm trying to tell you is that people are working on it as well. So this is what I just told you. So the fine one is the phase 3 study, and it is evaluating the efficacy and safety of Finerenone in adults with chronic kidney disease associated with type 1 diabetes. And this obviously, as we are talking from the word go, spironolactone, Finerenone, and finally this was again a landmark trial which showed that in heart failure with mildly reduced or preserved ejection fraction, this drug again is showing promise, and that was quite acceptable in view of what has been published in the past. So a drug which is protecting your heart, a drug which is protecting your kidney, a drug which is probably showing promise in non-proteinuric diabetic kidney disease, a drug which might show promise in type 1 diabetic patients. So I think this is a darling drug. And there are so many other trials going on which are looking into the different aspect of this. There's one trial which is in the pediatric population, again looking into this. There are a few cardiology trials which are going on. So over the years, next few years, maybe you will heard a lot about these drugs. I'll just quickly go through the drug, which Finerenone. It is basically used in 10 and 20 milligram of dosage. What is recommended that you check the serum potassium before using the drug, and then if it is between less than 4.8, no worries. If the GFR is 25 to 65, you can use 20 milligram. But if the GFR is low, you use a lower dose, which is 10 milligram. If the potassium is more than 5.5, you cannot initiate the drug. But if during course of treatment somewhere the potassium goes high and it is more than 5.5, you have to stop the drug, and then you readjust. You can restart it later on. So this is one of the worry, which all of us we have. We have been using this drug. I have been using this drug. Yes, at times it does cause hyperkalemia, but we have to manage it that. This has been previously, I told you, the half-life is 2 to 3 hours. That's why probably the drug is not causing that much hyperkalemia, and excretion is primarily through renal. So with this background, you can see that as if we all are discussing the drug here today, all the societies and guidelines, gradually it is there. You cannot ignore the drug. This is KDIGO guideline, which shows that this drug should be used. And then you name any American Association of Endocrinology. Unfortunately, you can't see that. And American Diabetes Association, European Society of Cardiology. So this drug has been recommended by all these societies, and it is part of the guideline. You have to use it in an appropriate setting, in an appropriate dosage. As a nephrologist, our dilemma is that chronic kidney disease in 2013 was 19th major cause of death. And then gradually it is going on. It became 13 in 2016, then 12th in 2017, and it is predicted that in 2040 it will be the 5th leading cause of death. So we all can imagine that it is the burden of chronic kidney disease is growing. So we need something to tackle that, and I think this is the way forward. You all know better than me. I don't need to talk about GLP-1 or anything else, but this drug is one of the pillar of the management of diabetic chronic kidney disease. I'm sorry, the last slide, which was very important, and that was a picture of JF17 Thunder and JC10 to how they combat. And for me, Finerenone is the combat master to tackle diabetic kidney disease. Thank you very much.
Thank you very much. Excellent overview of Finerenone. I'm Dr. Bashir Hanif. I'm the interventional cardiologist in Karachi. So I know you have talked about the benefits in kidney disease. I will just quickly go over, I know you touched a little bit about cardiovascular disease. But as a cardiologist, especially interventional cardiologist, the combination of diabetes and chronic kidney disease is always really a nightmare. The reason being, when somebody has diabetes, they end up having severe diffuse coronary disease, and it's not a focal disease, and if they become symptomatic, we are not really able to offer that much in terms of intervention, whether as an interventional cardiologist putting in a stent, or even if you send to a surgeon, he may not be able to put in a graft over there because the disease is so diffuse that, and the small vessels, that you're not able to do much. And the combination of chronic kidney disease makes it worse because we end up seeing so much calcification in the arteries, the coronary arteries, that becomes again a nightmare for a cardiologist, because our regular balloons and stents are not able to really open that calcification. Then we have to end up using the rotational atherectomies, and nowadays we have actually started using the lithotripsy, which we use for the kidney stones. We actually use in the coronary arteries to break that calcium in those arteries. So the chronic kidney disease and diabetes is really a bad combination generally, but specifically for cardiovascular disease, and it becomes really a nightmare for us. So any medication or any help we get in treating these patients, and any benefit we get for cardiovascular disease is really a music to our ears as a cardiologist. So when SGLT2 inhibitors came, that was really great. We were very happy that we have something now for patients with heart failure and for patients with even vascular disease, cardiovascular disease, and we started using it quite frequently in all our patients. I think the second challenge for cardiologists is really heart failure, and we have progressed a lot in terms of heart failure with the reduced ejection fraction. In terms of the medications, we have now 4 pillars of treatment, and including SGLT2 inhibitors. Now heart failure with reduced ejection fraction is really, the mortality is worse than any of the cancers, which we don't realize most of the times. And every hospitalization with heart failure decreases their mortality and increases their mortality, and they keep going down and down. So anything which could help is really good. So far, unfortunately, Finerenone doesn't have much data in heart failure with the reduced ejection fraction, because even in Figaro, the patients with the heart failure with reduced ejection fraction were excluded. So we don't have much data, but that did show there was some reduction in hospitalization from heart failure in addition to cardiovascular mortality in patients with heart failure with in cardiovascular patients. So we have to wait. Now we are actually, there are 3 trials which you mentioned: Redefine, Confirmation, and Finality. There are 3 trials going on which is going to test Finerenone in different categories of heart failure: mildly reduced ejection fraction, preserved ejection fraction, and reduced ejection fraction. But I think so far we had miserably failed in treating patients with heart failure with preserved ejection fraction, because we did not have any of the medications. Most of the trials had failed. Even the spironolactone did not show any benefit in heart failure with preserved ejection fraction. SGLT2 inhibitors were the first one to really show any benefit in patients with heart failure with preserved ejection fraction, and we do see quite commonly these patients. A lot of time previously we used to say if the ejection fraction is normal, we don't have to worry, it's not the heart failure, but we know now very clearly that patients can have heart failure with preserved ejection fraction, and they are the most difficult to treat. And now we have some data to say that Finerenone would be good for especially patients with heart failure with preserved ejection fraction, because we have a trial showing that. So I think so far we have limited data, but it is very promising, especially patients with heart failure with preserved ejection fraction, and I think cardiovascular disease as well. Hopefully, when the results of these 3 trials come up with the different ejection fractions, patients with the heart failure will definitely give us some more answers, and would be very helpful in patients with the heart failure. So I think we are happy as a cardiologist that we are getting more and more now addition to armamentarium of medications which we can use in these patients, which are really challenge in terms of treating these patients for us as cardiologists.
Okay. Thank you very much, Dr. Zahid Nabi, for your excellent talk. Initially, it was diabetes. Then came cardiometabolic syndrome. Then came cardio-renal metabolic. And finally came cardio-renal hepatic metabolic syndrome. I don't know where it will end. There are so many positive things about this drug, like it is non-steroidal.
Yes.
So very common side effects of spironolactone, like gynecomastia, even testicular atrophy, it is not there. So this is another good point for this drug. Actually, diabetologist shows holistic approach. The cardiologist mainly see cardiology, great, neurophysician, CT scan, MRI, then GIT, endoscopy, but diabetologists see whole patient as a whole. So this is good thing. So number of drugs of diabetologist is more than any other specialty, because we 2-3 drugs for diabetes, 1 or 2 drugs for hypertension, maybe for cholesterol, DPN. So our prescription is very long actually, because we have holistic approach. Thank you very much.
Do we have time for questions? Because we have a few questions. Let's just take one of those. Zahid, the question is, the efficacy of Finerenone is the same in proteinuric and non-proteinuric CKD or not?
Sorry. The non-proteinuric CKD, probably we do not have the data at the moment, because that the trials are just going on. It is on the basis of the conceptual, that it is an anti-inflammatory drug, it might work. जब भी कोई दवाई आती है तो फिर उसको drug company push कर रही होती है कि हर तरफ ही उसको use कर ले. So that data is not there. But yes, in proteinuric kidney disease, diabetic kidney disease, it has shown promise in terms of albumin creatinine ratio reduction. One important thing, एक चीज़ बड़ी important है जो मेरा ख्याल है हमें समझनी होगी कि ये drug जब use हुई उस वक़्त योर क्रेडेंस, डैपा CKD और वो डैपा HF और वो सारे ट्रायल शायद अभी नहीं आए हुए थे. So the question one can ask or one can think of is कि because SGLT2 ने तो इतना promise show कर दिया over the years that is now standard of care. So if a patient already is on SGLT2 or GLP-1 for example, and then you add on Finerenone, is that going to help you or no? Because ये जो हम जितने भी ट्रायल की बात कर रहे हैं यहाँ पे there was a very small proportion of patients who were on GLP-1 or on SGLT2 inhibitors, because the trial जब start हुए तो ये drug अभी उस वक्त ये trials नहीं आए हुए थे. So the question is that what will happen, जैसे अभी तो it's standard of care, you add on therapy जब आप करेंगे तो क्या कोई additive effect होगा, कोई synergistic effect होगा, or will it be just a redundant drug? So if you just to look into the subgroup analysis of the Fidelity and Figaro trial, you would see that those patients, small proportion, उसमें एक में शायद 4.6% patients they were on SGLT2, in other they were 8.4, and total in the pooled analysis it was around 7.5% of the patients who were on these drugs. So it showed that it has an add-on effect, So at the moment there is no such trial where both the drugs are combined together to see the effect. Confidence is a trial which is ongoing where Finerenone is added on SGLT2 inhibitor to see कि दोनों दवाइयों का combination से कितना benefit मिल रहा है. वो trial that is going on, that will be maybe in coming 1 or 2 years, then we can probably more confidently say that adding on therapy Finerenone on top of SGLT2 inhibitor has a beneficial role. So up till now we don't have enough data to say कि इसका add-on effect कोई होगा या नहीं होगा.
Zahid, one last and quick question, a wonderful one as well. Could Finerenone be used without ACE inhibitors and ARBs or SGLT2 inhibitors being there on the prescription? Or they have to be there on the prescription?
If we follow the literature, sir, they have to be there on the prescription. Because all the trials which we mentioned and the literature, published literature, there is not a single trial where the patients were not on ACE or ARB. Going back to 2015, they were ACE and ARB, and later on ACE and ARB was there. SGLT2 और GLP शायद नहीं है, लेकिन ACE ARB तो है, वो तो standard of care है, तो I think we can't do that.
Thank you very much.
Thank
So
you very
just a last comment from my side, Tahir. So I think we can't have an endocrine meeting without having cardiologist and nephrologist. And Bashir and I have been sitting together on many forums together because of first SGLT2 inhibitors and then Finerenone. So for all of us, the message is pretty simple. It's not diabetes management alone. It has to be diabetes, kidney, liver, and metabolic. It all has to go hand in hand. And not only diabetologists seeing all these four things, but even Bashir has to see it, Zahid has to see it, and that's the way forward in the holistic care of our patients. So thank you very much,
Thank you, sir.
Zahid, for a
Thank you
wonderful
very
talk.
much.
Thank you.
Thank you, sir.